good morning students today.
Good morning.
First lecture we just took a review regarding the anatomy of the nervous system. Today we will just have a recap regarding the same. For the students who were absent in the previous lecture, we will just take a review of the clinical neurology. So what we went through in the previous lecture is the neuroanatomy. Now before studying a case of clinical neurology, we should approach the patient according to the anatomical structures which are there in the neuroanatomy. So for studying the neuroanatomy, we will divide the nervous system into two parts. So what are the two parts of nervous system? As we all know, the two parts of nervous system, the nervous system is divided into central nervous system and peripheral nervous system. Now the central nervous system is divided into the brain, this is the brain, and this is the spinal cord. Okay. The brain again is divided into three types. So first is forebrain, then is the midbrain, and is the hindbrain. Okay. The forebrain compromises of what? It compromises of two halves together which are joined together, and they are divided by the sulcus. When we go through the surface anatomy, we can see that it is divided by the transverse fissure, the longitudinal fissure, okay, and they divide the different lobes of the brain. So how many lobes does the forebrain has? How many lobes it is having? The frontal lobe, then parietal lobe, temporal lobe, and the occipital lobe. Okay. Now each and every function of each and every lobe we will go through. The frontal lobe, what is the main function? It compromises of the major part of the brain. So this forebrain is specific, it is made up of what? What is the main part? It is the cerebrum. It is made up of what? Cerebrum. Okay. The cerebrum contains two hemispheres, two cerebral hemispheres, one on each side. Okay. Now this cerebrum is divided into four lobes, which is frontal, parietal, temporal, and occipital. Frontal lobe, what is the function? What does it do? It contains which area? It contains the motor area. Motor area, premotor area, which is, what does the motor area do? What does it do? मोटर एरिया का फंक्शन क्या है? It controls the functions of the body, all the locomotor system, the movements of the body is controlled by the motor area. So all kind of skeletal movements, flexion, extension, adduction, abduction, circumduction, rotation, internal rotation, external rotation, all kinds of movements of the body are governed by the motor area. So it is called as motor cortex. This area is called as motor cortex. Parietal area, parietal lobe, it contains all the sensory functions, controls the sensory functions. So it is called as the sensory area or the sensory cortex. The temporal lobe, what does it do?
Visual cortex.
It is called as the visual cortex because it is pertaining to the visual functions. And the occipital region, it is the auditory cortex. So like this all the functions of the brain are divided. As well as you all know, this major, the frontal cortex, it also is involved into logical thinking, then precision, decision making, and what? Planning and execution of the decision. So frontal lobe is the main lobe of the cerebrum, and it plays an important role in taking the decisions, planning and execution of the things which have been decided. So these are the four lobes. Then the midbrain, and then you have the hindbrain. So this is what is the central nervous system. Now from here the spinal cord starts, and the spinal cord is made up of, what is this? These are the spinal nerves. So spinal cord along with the spinal nerves which are bilaterally emerging from the facets, okay, or the recesses of the vertebrae. These spinal nerves along with the spinal cord compromises the peripheral nervous system. Now what happens? These spinal nerves together will come and they will form a, this is what? This is the plexus, nerve plexus. This is the spinal cord. These are the spinal nerves. The spinal nerves together collectively form the nerve plexus. The nerve plexus will give rise to what? Nerves which will go to the muscle fiber, and the point where it touches here, this is the neuromuscular junction. So the peripheral nervous system will include what? The spinal cord, the spinal nerves, the nerve plexus, the nerves which are going, and the point where it contacts the muscle and forms the neuromuscular junction. Now in this, the peripheral nervous system contains two divisions. One is what? The sensory division and the motor division. So it is having two pathways, afferent and efferent. Okay. So what is the main function of the brain? Main function of the brain is to collect the what? Sensations, information from different locations. So to collect the information from different locations, you need sensory receptors and sensory nerves for the information to arrive at the brain. Okay. So this information from the sensory perceptions, it will go, and so it will travel from here and it will go to the brain, which is the main cortex. Main, yahan par we are, the logical thinking is going on. Dhi, dhruti, smriti. It will go here, then it will have an previous experience of the same condition. Okay. For example, if you are going somewhere in a party and you meet some friend over there and you have already met her before. So you will recollect, okay, I have already met her before in some of my seminar, and you recollected her name, and then you said, oh, you are this Smita or whatever, Nancy, Geeta or whatever. So you recollected the past previous experience, and then when that sensory perception came to you, you saw her visually. So that is a sensory perception which is going from the peripheral nerves to the brain. The brain is again coordinating with the previous or the past experience when you recall that she is Smita from a seminar which you met, and then again that information of decision is being done in the brain, and that is again sent via the motor pathways to your organs. That this is this particular friend. So coming, information taking and information giving. Okay, information taking, processing, logical thinking, planning, executing, and taking the proper decision, and again reciprocating in that way. So these are the different functions the brain is doing. So CNS is only limited yahan par, but bringing the information and sending the information back, who is doing that thing? It is doing the peripheral nervous system, which involves the sensory and the motor nerves. So sensory is bringing in the information to the brain, and from the brain again that information is sending back for execution of the action via the motor pathways. Okay, so this is clear. Okay. So while studying this neuroanatomy and while studying clinical neurology, what all things we should keep in mind is 3 questions we are going to answer is: where is the lesion? Where is the lesion? What is the lesion? And why is the lesion? Now for understanding where is the lesion, we are studying neuroanatomy. Because the patient will complain of certain symptoms. For example, if a patient is complaining of weakness in the body, weakness of the lower extremities. Now for that weakness of the lower extremities, that symptom can come from a cortical lesion, wherein that patient has had any previous history of stroke or is undergoing some transient ischemic attacks, so that is the result where that patient is having weakness in the legs, or it can be a lesion in the spinal cord somewhere. Okay, there might be a nerve root compression over here leading to weakness of the lower extremities, or there can be a lesion at the muscular end, neuromuscular junction. So for localization of the lesion, we need to ask the patient n number of relevant questions. So where is the lesion, we will come to know by proper history taking and clinical examination. Okay. So for proper history taking, n number of relevant questions we need to ask. So questions pertaining to the body. VA, this is the patient. Brain related questions, that is cortical related questions we need to ask. For example, if there is a headache or there is a paresis or weakness in the muscles, cortical related symptoms we can ask whether that patient had any previous history of stroke, so that we will come to know कि वहाँ पर कोई या any kind of hypertensive history is there, or any kind of aspirin that patient is taking. So probably long-term indiscriminate use of aspirin might have caused that hemorrhagic stroke. So all these relevant questions we need to ask. So we will come to know that whether the lesion is in the cortical region. Or you can ask if you are suspecting if it is an accidental trauma resulting in compression of the nerve, you can ask the relevant questions whether the patient had a history of accidental injury or a traumatic fall. Okay, so this kind of relevant questions we need to ask so that we can come to a conclusion whether it is a spinal origin region or whether it is an cortisol lesion or anywhere between. So इसके बाहर कहीं पर लीजन नहीं जाएगा. It might be in the brain, it might be in both the systems, CNS as well as PNS. कहीं पर तो lesion है. You have to locate where the lesion is by asking relevant questions to the patient. That is the reason history taking is very, very important. What all questions you need to ask is very, very important. Now in history taking, what we will do first is, what is this? Chief complaints. That patient might having n number of complaints. Like if a patient is having weakness in the legs, he might be having some kind of tingling, numbness, or he might be having pain, or he might be having paresthesias, or he might have a foot drop. Okay, so these are different kind of complaints he might be having. So out of that 10 number of complaints, we have to choose what are the specific ones and pertaining to the disease. Now if along with this the patient is complaining of nausea, vomiting, abdominal distension, constipation, these are the other complaints. Okay, so we have to at least record 4 to 5 cardinal features. Okay, then each and every feature we will write the ODP. What is ODP? onset, duration and progression of the disease. So onset is when did the complaint start? Okay. How many days did it took? Duration is how many days the complaint was there, like maybe 1 month, yeah, few seconds back, few minutes back, few days back. And progression is how fast the complaint is progressing. Like if there is weakness in the legs, how the previously that weakness was only limited to your toe region, now the weakness is overall the whole leg. So this is the progression of the symptom. Okay. For like that you can say headache also. Previously the headache was localized only in one part of the temporal region. Now I can feel that the headache is all over the head. The pain is there. So what is the progression? So onset, duration and progression of each and every complaint you have to record over here. Then you will have certain associated symptoms also. So associated symptoms might be, he might be having fever, okay, he might be having nausea, he might be having vomiting, he might be having difficulty in micturition or burning sensation in the urine, so or incontinence of urine. So whether that particular symptom is really associated with the original symptom, whether there is any link between these symptoms, you will have to find out. So whether if this is a cardinal symptom or it is an associated symptom. For example, if vomiting is there in a patient of a traumatic injury, definitely it needs to be addressed, because the center of vomiting is there inside the brain. So any kind of traumatic injury, any kind of history of fall, after that if the patient is having projectile vomiting or vomiting, we need to rule out if there is any brain injury, where there is any tumor formation or whether any kind of mass has been built up, any kind of bleed is there, hematoma is there inside the brain. So this being an associated symptom, we just cannot neglect it. So you have to differentiate if that associated symptom is equally important or it is not equally important, and whether it is relevant to the main cardinal features or not. Okay. Then you have clinical examination. Clinical examination, we have a range of examinations to be done. So under clinical examination, we have nutrition of the muscles. So basically clinical examination deals with sensory examination and the motor function. So if we go through this, okay, we can go from above to below or from below to above in finding out where the lesion is. So if we are going from from above to below, you can take n number of investigations, but you should be clear where the lesion is so that you can tell the patient a precise investigation which need to do. The relevant investigations only we will do. So in this we will check the nutrition of the muscles. Then we have the tone of the muscle. Motor examination. This is the motor examination. Then we study the power of muscle. Then what else? Coordination. Then involuntary movements. Then reflexes. And then you have gait. So nutrition of the muscles, tone of the muscles, power of the muscles, coordination of movements, involuntary movements. So from here to down if we go, okay. So like that, first you address the central nervous system. So central nervous system, and then you go to the peripheral nervous system. So while checking the peripheral nervous system, we are checking all these things. Okay. Then the cranial nerve examinations. This is the sensory examination which we are doing. Okay. So one by one we will see all of that. So we got ki where is the lesion if we want to find. We are studying the neuroanatomy. In neuroanatomy we studied different lobes, the functions of the different lobes. Okay. The functions of each and every organ of the brain we revised in the previous lecture, so with that we are not going to repeat it again. Then here we have to take the history taking properly by asking relevant questions. We will see later on what are the clinical symptoms of pertaining to neurology we should ask the patient in a patient of any kind of nervous system disorders. Then we have the clinical examination wherein we divide it into sensory and the motor function testing. In sensory examinations we will do all the cranial nerve examinations, and in motor system we have the nutrition of the muscles, the tone of the muscles, the power of the muscles, the involuntary movements, the coordination of movements, the gait and the reflexes. Okay. Then we will come to what is the lesion. So what is the lesion? What is the pathology which is causing the lesion? Whether it is a degenerative pathology, whether it is an compressive pathology, whether it is an obstructive pathology, whether it is relating to any kind of less amount of diminished blood supply to the brain which is causing the pathology, or whether it is any kind of hemorrhagic pathology. So what exactly is the pathology? That will be answered in what is the lesion and why it has occurred, why the pathology has occurred. For that we will have a group of symptoms which is the etiology, the etiology of the symptoms. If this symptom has occurred, what is the reason behind its occurrence? What is the etiology? So for answering why, we are having a group, that is, first is V. V is any kind of vascular damage is there inside the brain. So any kind of vascular etiology is there, like hemorrhagic, or stroke, or infarction, or ischemia is there. So any kind of vascular damage is there. Then I stands for any kind of infections. So you have as in cerebral malaria or meningitis, meningeal irritation is there, tubercular meningitis, so you have a bacterial infection of the brain. There can be viral encephalopathy wherein exposure to virus history is there. So these are the different types of infective foci. We need to find out what are the infective foci, whether it is a bacterial one, a fungal one, mucormycosis, fungal hai na? So we need to identify the infective foci, what is the origin, whether it is a bacteria, virus or a fungus. Okay. Then T is any kind of tumors or toxins. So you have different kinds of toxicity. You have drug toxicity, you have lead toxicity. Indiscriminate use of certain rasa aushadhis also causes certain kinds of toxicities. Lead accumulation in the brain. Okay, you get different kinds of headaches, different kinds of symptoms are there. Then you have any kind of tumor which is pressing on the brain and that is causing an headache, or any kind of nystagmus or any kind of vertigo. So any kind of symptom, you should never neglect that symptom. You should go deep down to the symptom and find out why the symptom is occurring. For example, a fever causing, whether that fever is related to any kind of infection or not. Maybe it is a mild fever. You never know, it is a case of Cox. So each and every symptom should be addressed and should be reached to the ground level. Why that symptom is there in the patient. If the patient is showing some symptom, it means something is wrong in the body. That is the reason it is showing the symptom. So each and every symptom should never be neglected. You should always go deep down and hunt for the infective foci, why this symptom is being seen. So then we have any kind of addictions. If the patient is having overuse of alcohol or any kind of addictions he is into smoking, taking any kind of drugs, barbiturates or something, so that are causing any kind of withdrawal symptoms. Abruptly, if a patient is withdrawing alcohol, he can show any kind of nervous system related disorders. So any kind of addictions that patient is into, that also we need to ask. Then any kind of autoimmune disorders. So patient might have different kind of diseases. What are the different autoimmune disorders? Rheumatoid arthritis, then connective tissue disorders can be SLEs and all, psoriasis, these are all autoimmune disorders. Then M is the metabolic disorders. If a patient is having any history of diabetes, any kind of electrolyte imbalances that patient is into, acute diarrheal conditions, that might also result into having nervous tissues, different kind of symptoms, metabolic disorders and endocrinal disorders. So patient is hypothyroid and he is on some kind of medications. So all this history should be taken into account. Then we have iatrogenic disorders. What is iatrogenic? No, no. Unknown cause is not there.
The disease occur due to other diseases like old
physician chemist treatment.
It's because of any kind of drug toxicity. The patient is already on, suffering from an X disease for which he is taking a medication, and the side effect of the medication is causing a different disease or a different symptom related to nervous system. So there are n number of examples we can give: long-term use of steroids, long-term use of anti-epileptic drugs, use of isoniazids, the anti-cox treatments which they are giving, isoniazids or cyclosporin. So all this cyclosporin. So all these drugs, they have what? They are neurotoxic. They might cause convulsions, they might cause dementia, they might cause depression. So various drugs, IQ quotient of the patient can be reduced. Patients who are on long-term use of anti-epileptics, the IQ quotient is decreased, the intelligence is decreased, the memory is decreased. So like that, there are n number of iatrogenic drugs which causes nervous system, different kinds of symptoms relating to the nervous system disorders. Then seventh is nutritional. Any kind of deficiency in the nutrients. If a patient is malnourished, then he might have various nutritional disorders. For example, folic acid deficiency in a pregnant female, that might lead to neural tube defects. Folic acid is being given for first 3 months, wherein the neural tube is developed during the first trimester of the pregnancy. So nutritional disorders, maybe it's an iodine deficiency, or folic acid deficiency, vitamin B6 deficiency, vitamin B12 deficiency. Who will prepare a chart regarding this? Nutritional deficiency symptoms pertaining to nervous system. Who will prepare the chart? In children and adults?
I will.
You will prepare? Okay, all the macro and micronutrients which are deficient in our diet, and that will lead to development of some nervous system symptom. That chart you need to prepare. Okay, you can give it at the end of this month. And then you have it is syndromic, or you can say it is genetic. So these are all the factors which we need to ask the patient. So genetic, we can see genetic disorders are there in the patient. For example, folate deficiency will lead to neural tube defects. It might produce genetic disturbances. Or a patient having a history of chicken pox or mumps or measles in the childhood, that patient might have torch panel test positive and might suffer with primary infertility resulting in habitual abortions or miscarriages. So person with even a history of miscarriages, you might have to ask a history of all this torch panel positive, or you need to investigate the patient for the torch panel test by doing this test. So this is, if you answer all this, if you ask all these things relevant to the case of a patient, you might arrive at a specific diagnosis. That is, it will not be a confirmed diagnosis, but at least it will be a provisional diagnosis. And then you can, when you find where the lesion is, you can tell the patients to undergo different kind of investigations. So if you are suspecting that the lesion is in the brain, if the patient is having stroke, weakness of half side of the body, then you can tell the patient to go for CT scan or MRI. If you feel that MRI of the brain, if you feel that the lesion is in the spinal cord, you can tell the patient to go MRI of the spinal cord, MRI of the spinal cord. So because these tests are very, very expensive, all the tests you cannot recommend the patient at the time. So you need the precise diagnosis, at least the nearby diagnosis, the provisional diagnosis, to tell the patient what investigation he has to do. If you feel that it's more related to endocrinal problems, you can tell to go for endocrinal assay, T3, T4, TSH, or maybe any pituitary hormones के वजह से उसको disturbances हो रहा है, तो you can suggest him to go for those kind of test. Okay? And then you can tell the patient, once the diagnosis is fixed, the treatment part is very easy to tell. So basically this is a small picture of how to approach a case of clinical neurology. Now in this we are going to study each and every clinical examination. So, but before starting the examination, to assess the patient, what we need to think and how we need to think, this is a small review of how we need to think about that particular patient. Now we will go one by one. Who has got the measuring tape? You have got the measuring tape? First examination which we are starting is nutrition of muscles. This is the first clinical examination which we will be doing. Now when a patient is walking inside your clinic, you can just observe and inspect the patient while he is walking, how his gait is, how his walking style is, how his posture is, how he is able to maintain his coordination properly or not. While walking, whether his foot are properly balancing his body, he is maintaining his equilibrium or not, whether the limbs, both the limbs and the muscles of both the limbs are properly nourished or not. So just by inspection we can find out n number of signs and symptoms without the patient telling us. So that is the reason gait is a very, very important examination. Even if all the examinations we don't do, and even if we just study the gait of the patient, that can give you relevant information regarding what is the probability of the and where is the lesion. You can arrive at a diagnosis just by inspecting the gait of the patient. So first is the nutrition of the muscles we are studying. When we look at the patient overall, all the body we have to see how the muscles are, whether that the sahanan and the saratva. In Ayurveda what we will see, the mausasar, है ना? तो mausasar कैसा है, उसका sahanan कैसा है, that is what we are observing. So sahanan is the nutrition of the body, how well built that particular individual is. Whether he is lean body, whether he is thin body, whether he is obese, whether he is properly nourished, medium constitution person. So we have to observe all these things. Then we will overall inspect him, and individual muscles also we are going to inspect. As well as we will inspect bilaterally. So symmetrical muscle we will study. So suppose if we are inspecting the muscles of hand or the muscles of face or the lower limbs, we will compare it bilaterally. Now how it is done practically is, we are taking a measuring tape. Come a model, someone. कोई भी आ सकता है? Yes. Now each and every muscle we need to inspect. Okay. Now that inspection I have done, I have seen all the muscles are properly formed, properly built. The muscles are having a special contour. We cannot, they are not atrophied or emaciated. Okay, they are well built and nourished. So uska sar or sahanan, everything is proper. Now I will exactly found if there is a small variation, I will not be able to guess or know that variation just by inspecting it. So pratyaksha praman is by measuring it with the help of a measuring tape. So how you do it? You take a specific point. For example, if I am studying the muscles of the upper arm, I will take the midpoint of the upper arm. Okay, and I choose 2 points. One is the upper point and one is the lower point. Okay. So upper point, if I am taking this humerus and lower point I am taking the olecranon process. In midway of that I will mark a point. Okay, I will take a measurement from here. So suppose if I am taking, this is 10 centimeter, if I am taking, choosing a midpoint between this, okay, 6 centimeter. From this I will mark this point and I will take the circumference. I will write this circumference, then I will compare this with the opposite hand. So similarly, how much dimensions I have calculated for that hand. If I have taken 5 centimeters intermediate line, similarly from here I will measure that 5 or 6 centimeters. I will mark that point and I will take the circumference of this particular muscle. So these two muscle circumference, if I am combining, not combining, if I am correlating both this, they should be same and there should not be a difference of more than 2 centimeter. If there is a difference of more than 2 centimeters, it means that the muscle is emaciated or the muscle is atrophied or the muscle is reduced. The sahanan kam ho gaya hai, saratva kam ho gaya hai. Similarly, you have to check in all the extremities, the upper arm, the forearm. Similarly, the lower extremities also you will check it in that manner. So anybody wants to check? Come here. Yes. Yes, you start. He will check yours. Yeah, come here. So we are studying the nutrition of the muscles. Yes. Now you have to study the nutrition of the thigh muscles or the calf muscles. How you will study? You have to mark a point. Okay. So if you are taking the patella as the point, don't laugh. Yes. Stand here. And the styloid process of the ankle joint. Okay. So take a midpoint between that. First you measure the full length, then take a midpoint between that. उसका midpoint ले लो. Where the muscle is in maximum circumference of the muscle. You have to expose the muscle. Actually, you have to expose the muscle properly, and then the circumference where the muscle is fully developed, that circumference we need to take. Okay. Now you mark it. Midpoint and take the circumference. Take the circumference. You have to expose the patient, not like that, wearing the jeans and all. Okay? And this also you have to measure it simultaneously. It should be. So what is the test? What we have to measure here? What we are measuring? Circumference of the muscle. What is the difference? If the difference is greater than or more than 2 centimeter, it is pathological. Keep it in mind. Any girls? Two girls come here. You front benches. Come. Yes. Now here from oligramma process to the styloid process is there. Which is the midpoint you have to take, and then find the girth of the muscle or the circumference of the muscle. You calculate it and compare it with the other arm. Same dimensions. And then find a midpoint. Midpoint उसका कितना था? उसको उतना ही लेना है. So don't know if all the measurements, both the measurements are matching, then she is normal. Okay. So each and every individual muscle we need to measure like this. Even the inspection of the thoracic muscles, inspection of the back muscles, we have to see whether they are nourished properly or not. Okay. Then where is the wasting of the muscles seen? Which diseases you will find the wasting of muscles? शोष, माउस शोष. कौन से व्याधियों में दिखता है? राज्यक्षमा और शोष एक व्याधि है एज अ सेपरेट व्याधि. वात प्रकोप में कार्श्य बताया है. कार्श्य इज ऑल्सो व्याधि. देन which all vyadhis we have? कौन से व्याधि बताया है? राज्यक्षमा. इम्यूनो कॉम्प्रोमाइज स्टेटस जो भी किसमें होता है? कौन से व्याधियों में होता है? HIV, STDs, हाइपोथायरॉइडिज्म में होगा. हाइपरथायरॉइडिज्म, देन marasmus, Kwashiorkor syndromes, then we have cancers, malignancy. So then if the muscle is atrophied, paralytic patients where the muscles are not in use, okay, that also can cause the atrophy of the muscles can be seen in those patients also. So what will we will observe? We will observe if the muscles are atrophied, whether the muscles are hypertrophied also. So difference of 2 centimeters means not only it is decreasing, the muscle can be ज़्यादा सहनन भी हो सकता है, अति सहनन भी हो सकता है. So that will be hypertrophy of the muscles. Then asymmetrical muscles, asymmetrical development of the muscles. Then fasciculations, we are inspecting all these things. Myotonia and the tremor which is there in the muscles. Okay. Pseudo hypertrophy of the muscles. What is pseudo hypertrophy? दिखने के लिए मसल बड़ा लग रहा है, but the muscles क्या है? टोन कैसा है मसल्स का? It is improper. सिर्फ दिखने के लिए ऐसा लग रहा है मसल इस काफी nourished है, वो ज़्यादा पोषण हो गया है उसका. The bulk of the muscle is very good, but the tone of the muscle is not good. So that is pseudo hypertrophy. The muscle power is decreased in this kind of patients. Then generalized wasting will be there in advanced tuberculosis and malignancy, and localized wasting only a small muscle or muscle group. तो कौन से डिसीजेस में उसमें वेस्टिंग हो जाएगा? स्मॉल मसल ग्रुप और लोकलाइज वेस्टिंग विल बी सीन इन एनी काइंड ऑफ पैल्सी ऑफ द मसल्स. फेशियल पैल्सी में इतना ही मसल तुम्हें दिखेगा, पूरा नहीं दिखेगा. सो देयर इज ओनली लोकलाइज्ड वेस्टिंग ऑफ द मसल्स विच इज सीन. सो एनी काइंड ऑफ nerve palsy There you will find localized wasting of the muscle. Then early muscular atrophy, dystrophy. There also you will find localized muscle wasting is there. And if there is a patient of poliomyelitis, old poliomyelitis, ऐसे में भी आपको specific muscle group wasting दिखाई देगी. Then any kind of secondary diseases like arthritis वगैरह है, so long standing chronic arthritis might result into wasting of the muscles. वात रक्त में भी हमने देखा संशोष ये निर्माण हो जाता है. अगर वात प्रकोप बहुत ज़्यादा हो जाता है तो वक्रत्व आ जाता है संधियों में, which is resultant because of शीत गुण वृद्धि of the वात resulting in atrophy of the muscles. So that is also secondary diseases might produce atrophy of the muscles. What is the time? हो गया? बंद कर. So remaining part we will do it in the next lecture. Pardon?
ચાલુ કર્યું તો